The following video presents our concepts to treat urethral stricture disease and is based on our experience and the lessons learned after more than 2,000 urethral reconstructions in more than 20 years. The treatment can be done endourologically, either by direct vision urethrotomy or dilatation, or by open surgery, for example anastomotic repair, by tissue transfer, or as salvage procedure by perineal urethrostomy. The urethrotomy has a success rate of 20 to 30% in case of primary short bulbar stricture, but it's not successful in case of extended strictures irrespective of location. Therefore, it should be considered as a palliative procedure. 3 to 4 weeks before the planned open reconstruction, we routinely perform an urethrotomy and establish the exact stricture length. By doing this, it's almost always possible to close the corpus spongiosum over the graft to avoid diverticula. In case of short bulbar urethral stricture and distraction trauma, the anastomotic repair remains the procedure of choice. In case of anastomotic repair, we fill the bladder via suprapubic tube and insert a Freudenberg bougie through the bladder neck, till to the proximal obstructed urethra, which can be palpated perineally. A transurethral 20 French catheter is inserted in the distal urethra and the distance between the two ends is marked. Skin incision, division of bulbar muscle, and development of both urethral ends and mobilization of the distal urethra to get enough length for an anastomotic repair. The urethra is spatulated on both sides to get a wide open anastomosis, calibrating both ends by a 30 French bougie. The anastomotic repair is done with 6O monocryl. To avoid tension on the repair, we fix the urethra at the corpus cavernosum by 4O vicryl. Closure of the bulbar muscle and subcutaneous tissue by running sutures 4O monocryl. An indwelling catheter 18 French is placed for 3 weeks. Extended strictures are ideally treated with tissue transfer. In nearly all cases, we use buccal mucosa graft. As stated earlier, the exact length of the graft is established during the urethrotomy 3 to 4 weeks before the open reconstruction. We use stay sutures and a Langenbeck hook to open the mouth and inject saline adrenaline solution for better dissection of the graft. The defect is closed by 5O vicryl rapid. The graft is completely defatted. There's always plenty of graft even in case of penurethral strictures. In case of bulbar stricture, The patient is positioned in extended lithotomy position. A 20 French single-use catheter is inserted till to the stricture and can be palpated perineally. Opening of the stricture until both ends are wide enough for a 30 French bougie. The graft is sutured ventrally by running 6-0 monocryl. A 18 French silicone catheter is inserted for 3 weeks and the graft is covered by the corpus spongiosum by 4-0 monocryl. Closure of the wound by running sutures 4-0 monocryl and 2-0 vicryl. In penile stricture, including the meatus, we incise the skin parallel to the urethra. A 18 French catheter is inserted, the urethra is developed and the plane between urethra and glans is opened. The urethra is incised. The graft is sutured ventrally with 6-0 monocryl and then pulled through the glans to fix it at the meatus. This technique avoids the transection of the glans and we never experience problems regarding infections and graft taking. A 20 French single-use catheter is kept in place for 1 and suprapubic tube for 3 weeks respectively. In case of panurethral stricture, we perform a 5 cm perineal incision, dissect the complete urethra and pull the penis through the perineal incision. In case of panurethral stricture including the meatus, we use the same technique as for the distal urethral stricture reconstruction. Opening of the complete urethra and calibrating both ends by 30 French bougie. corpus, spongiosum can be closed by 4O monocryl, even in the penile part of the urethra, due to the urothrotomy performed some weeks before. A suprapubic tube and a single-use 20 French catheter is inserted for 3 and 1 week, respectively. In complicated cases with extended scarring, less vascularized penile skin and stricture, we prefer a staged reconstruction. In case of penile stricture, we open the urethra, resect all the scarred tissue, and transplant the buccal mucosa graft using 6O monocryl and kilt it on the corpus cavernosum. The tubularization of the graft is generally performed after 3 to 6 months, and in case of skin shortage, the neourethra is covered by a vascularized scrotal flap. Closure of the urethra is performed by running 6O monocryl over a 20 French single-use catheter. By preserving as much subcutaneous tissue as possible, tubularization is facilitated. All our patients are investigated after 3 weeks by urethroscopy and a VCUG to exclude leakage. A superficial necrosis during the urethroscopy does not influence the result negatively. In summary, urethrotomy under direct vision has a high recurrence rate, and it should be considered more or less as a palliative management of the stricture and has rare indications. In our department, we use it to simplify the reconstruction, which is performed 3 to 4 weeks after the urethrotomy. Anastomotic repair is used for short bulbar strictures and the treatment of choice for distraction trauma. Referring to the literature, there might be some more sexual disorders after anastomotic repair, and that's why we use it generally in case of distraction trauma only. In case of non-traumatic and extended stricture, including penile or meatal stricture, tissue transfer is necessary. In most cases, we use buccal mucosa graft. In case of completely destroyed urethra with extended scarring of penile skin, the staged procedure delivers far better cosmetic and functional results. The use of mesh graft or a perineal urethrostomy can be a solution for salvage cases.